Hey, what's going on, guys? And welcome back to another video of Keep It Simple Stupid. All right, well, let's go ahead and get into this video. So my previous video, we discussed a low thyroid state emergency. Now we're going to discuss the opposite, which is going to be a hyperthyroid state emergency, and that will be thyroid storm. And of course, I'm going to try to explain it as simple as possible so that hopefully you all watching will have a better understanding of thyroid storm. So as always, let's go ahead and discuss the definition. So it is severe uncontrolled hyperthyroidism characterized by multi-system organ failure. That is thyroid storm. All right, now I've kind of written out some points here. So how does this present? Well, first of all, if you think about how hypothyroidism presented or how myxedema coma presented, well, let's think about the opposite. So you're going to have hyperpyrexia. So you're going to have a high temperature, a fever. You're going to be tachycardic. You're going to have tachyarrhythmias. You're going to be confused, agitated, altered mental status, and then nausea, vomiting, and diarrhea. The next question is, so how is this diagnosed? So generally, from the information I can see, it is a clinical diagnosis. So what does that mean? Is you're not necessarily basing it off of lab values that you find. You're basing it on how the patient presents. But there are some scoring tools that can help you identify if it's more or less likely. So the big one here, it's the Birch-Bortofsky point scale for thyrotoxicosis. Now, I'm not going to get into it in great detail here, but you could look it up on something like MD Calc or Google. But basically, based on the presentation of the patient's symptoms, you're going to enter that into a little calculator, and it's going to give you some different scores. Now, what do these scores mean? So greater than 45 is highly suggestive of thyroid storm. A score of 25 to 44 means it's suggestive of thyroid storm, and then less than 25 means it is unlikely. And then another scoring tool that you can kind of look up, it's going to be the Japanese Thyroid Association JTA criteria. Why is thyroid storm bad? And at the end of the day, the biggest concerning thing about it is that it can lead to heart failure and shock. Why does it do this? Well, T3, T4, they increase the metabolic rate, oxygen consumption, and they cause excess heat production. Now, some basic physiology and pathophysiology. You have your hypothalamus, which is producing thyroid releasing hormone, which stimulates the pituitary to produce thyroid stimulating hormone, which then tells the thyroid, hey, why don't you make T3 and T4? Now, a little important bonus point here. Secondary hyperthyroidism is caused when there is too much either TRH being produced or TSH, whereas primary hyperthyroidism is when the thyroid itself is releasing too much T3 and T4. So treatment, step one, supportive care. If the patient's not protecting their airway, intubate them, give them fluids potentially along with dextrose. And the reason for that, again, just think about thyroid storm. Your body is at a hypermetabolic state. Everything is firing on all cylinders. And if you're at a hypermetabolic state, you might be burning through glucose, so you may need to provide the patient with more glucose. All right, now step two. Now we're getting into some of the pharmacology. So you want to inhibit peripheral adrenergic effects. So all this thyroid hormone is making you hyperadrenergic. So what can you do to help this? And that's going to be by using a beta blocker, specifically propranolol. Now, propranolol is non-selective. So what will this do? It'll help decrease afterload, and it will also decrease the heart rate. And then it can be given IV. And the resources I saw recommend 1 to 2 milligram boluses every 10 to 15 minutes. Or oral, it could be 60 to 80 milligrams every 4 hours. And another important component of propranolol is that it helps prevent the conversion of T4 to T3. And just remember that T3 is the more potent hormone at the tissue level. Now let's move on to step 3, which is inhibit new thyroid hormone synthesis. The medication class that can be used for this is something called thionamides. And it can be methimazole or propylthiouracil. Kind of a mouthful there. So propylthiouracil, PTU, what does this do? It blocks thyroid hormone synthesis, and it helps reduce the conversion of T4 to T3. The dose generally is 500 to 1,000 milligrams, a loading dose, and then 250 milligrams every 4 hours. Important thing to understand about PTU is that it can cause hepatic injury. So it's something to think about. And maybe if you're on an admitting service, just remembering to check LFTs or liver function tests. And the other option is methimazole. Now, this one blocks thyroid hormone synthesis, but it does not block conversion of T4 to T3. The dose is 60 to 80 milligrams per day. And a very important point to understand about methimazole is that it is contraindicated in the first trimester of pregnancy. Contraindicated just means you should not give it in the first trimester of pregnancy because there's a high teratogenic risk. So what that basically means, it could damage the fetus. Now we're moving on to step 4, which is inhibit thyroid hormone release. And this is done with iodine. SSKI, what does that stand for? Saturated solution of potassium iodide. Now, an important component to understand about this is that you have to start it at least 1 hour after the thionamides. So that's the methimazole or the PTU. And the question is why? Iodine can be used to create new thyroid hormone. So you need to block the synthetic pathway for producing thyroid hormone first, and through something called the Wolff-Chaikoff effect. And the Wolff-Chaikoff effect is the temporary shutdown of thyroid hormone production after a large iodine load. Now again, it is important that this is given at least 1 hour after the thionamides. Reason being is that if you have not shut off that synthetic pathway, giving more iodine could potentially make things worse. However, if you've blocked the pathway for creation of thyroid hormone, then giving that larger dose of iodine will shut down thyroid hormone production. And then the dose here I looked up was 5 drops, 250 milligrams every 6 hours. Moving on to step 5 now, which is preventing additional peripheral conversion of T4 to T3. And this is done with something called hydrocortisone. Hydrocortisone, you're going to give a 300 milligram IV load, then you're going to do 100 milligrams every 8 hours. So this does a couple things. One, it also helps inhibit peripheral conversion of T4 to T3. And then also it is prophylactic against adrenal crisis. So when you're in a hypermetabolic state, your body is burning through cortisol, which is made in your adrenal glands. The reason you would give this medication to hopefully prevent adrenal crisis is that you are providing more of the thing that your body is burning through at a high rate. So you're giving the hydrocortisone to replete that cortisol. Now moving on here, reaching the end, step 6 is preventing reabsorption of thyroid hormone, and this is done through a medication called cholestyramine. What does this do? It decreases thyroid hormone reabsorption from the enterohepatic circulation. And the dose for this is 4 grams every 6 hours. And then finally moving on to step 7 here. So what is the definitive treatment? And generally that's 2 things. It's either surgery or radioactive iodine ablation. And that's not something you would necessarily look at during the acute phase of stabilizing the patient, but I think it's important to understand just for your own knowledge that that's generally the definitive treatment for thyroid storm. All right, guys, well, that's all I have for you today. This is a bit of a longer video compared to what I normally make, but a lot to cover here. Again, I hope this was helpful. As always, like, comment, subscribe. If there's any other topics you would like me to cover, please let me know. And I'll see you guys next time.